Welcome to the Graston Technique Forum. I'm Todd Lugar, President and CEO of Graston Technique. Today's podcast will focus on the importance of IASTM education. We'll also discuss evidence-based research regarding the Graston Technique. My guests today include Dr. Terry Loghmani from Indiana University. Terry has conducted numerous studies and has investigated the effects of instrument-assisted soft tissue mobilization via the Graston Technique versus manual massage. She's also been associated with Graston Technique since 1994 and has served as the company's first clinic director and first director of education. She also is an author on all 3 editions of the M1 training manual. Currently, she is an associate clinical professor in the Indiana University Doctoral Physical Therapy program. Beside her teaching experience, she has made many presentations at professional conferences, including the American Physical Therapeutic Association's Combined Sections meeting. Her long-standing clinical experience with Graston Technique has established herself as certainly authority in the GT management of myofascial conditions. Also with me today is Mike Ploski, Director of Strategic Planning, PT for Graston Technique. As a GT trained clinician since 1996 and a GT instructor since 1998, he brings a wealth of knowledge to this podcast. Mike is a board-certified orthopedic clinical specialist and certified golf specialist. Currently, he serves as a part-time clinician for a rehabilitation company based in the greater Indianapolis area. He also is a guest instructor in orthopedic manual therapy at the University of Indianapolis. He was a clinic director in Indianapolis for 12 years for a national rehabilitation company. Prior to that, he was a physical therapist and athletic trainer for the PGA Tour and the kart racing series. Welcome, Terry and Mike.
Thank you, Todd.
Well, let's first discuss research. Terry, you've published 4 research studies on the effects of instrument-assisted soft tissue mobilization via the Graston Technique versus manual massage. Your most recent studies have been published in the Journal of Orthopedic Sports Physical Therapy in 2009 and the British Journal of Complementary Therapies in 2013. How would you respond to when you hear clinicians say that Graston Technique is not evidence-based?
Well, the evidence in support of the Graston Technique, instrument-assisted soft tissue mobilization, is mounting and emerging. There are different levels of evidence. There's a hierarchy of evidence. And the Graston Technique has evidence that's available at the 2nd, 3rd, 4th, and 5th levels, with the 5th level being expert opinions and based in basic science. And we have animal model studies that looked at both tendon pathology as well as ligament pathology, all of which had positive outcomes in favor of the Graston Technique to the untreated limb within these animal models that had injured limbs. We have multiple case reports with a variety of diagnoses from shoulder pathology, lateral epicondylosis, plantar fasciitis, patellar tendinosis. We have case series that have been published on heel pain and knee pain. We have randomized controlled clinical trial looking at carpal tunnel syndrome. What we need are additional studies at higher levels, such as randomized controlled clinical trials that are significantly powered in order to detect that clinical difference.
Now, obviously, the company is very supportive of research in these areas, and we want to make sure that more efforts are being conducted. Mike, as a clinician, practicing clinician, how important is evidence-based research to you?
Well, it's extremely important from a clinician's standpoint. We're trying to provide treatments that have the best available evidence in terms of their efficacy. And so when people come to our courses, they're really wanting that evidence to back up what we're teaching them. And so we need to be able to provide that evidence. So as an instructor, I found an extreme necessity to stay current with the literature and the research just to help with my credibility for my class. In addition, just to being able to provide the best education to our students who come to our trainings. I feel like it's our role as experts in our field to provide the best evidence and the best education when it comes to the treatment of soft tissue dysfunction, whether or not it's instrument assisted or just using our hands. These instruments are not replacing our hands. We're still using our hands. This is still a manual approach. We're just using instruments to be more effective at it. We know that there's evidence out there for cross-friction massage, for example. But doing a friction with an instrument is so much more effective than doing it with your fingertip. It's so much more specific, it takes less pressure, it's more comfortable for the patient.
And Mike makes a good point. The evidence that's out there for massage is huge. There's been systematic reviews, and really this is a form of soft tissue mobilization, a form of massage that's taking what you can do with your hands alone to that next level.
Now, Terry, you're currently in the process of conducting research study with GT and ultrasound, diagnostic ultrasound. Can you give us an update on the conditions being studied and when the results might be published?
Well, I'm not able to disclose the details of those studies because they are still in progress. But I can let you know what we're looking at. We're looking at the effects of the Graston technique on Achilles tendinopathy, plantar fasciitis, and on scar, painful scar, in particular in amputees that have residual limb pain and phantom limb pain.
Now, research was also conducted at Duke University by Faltis et al. In 2012 regarding the treatment of a quadriceps tear using the Graston technique. What were the outcomes of that study?
The outcomes were promising in that they were able to show, using the diagnostic ultrasound, that there was an improvement in soft tissue quality, not so much in reduction of the size of the area of the injury, but in the swelling around that region, and also the self-reported outcomes of decreased pain and improved function levels were encouraging.
Now, given that and given your activity, is it safe to say that the research community is obviously focused on IASTM and Graston Technique in particular, and that they see the importance of studying this type of modality?
It's been exciting to see studies that have been coming from other universities that we weren't even aware were in progress, and looking at different diagnoses. So that tells us that this has become an area of research in and of its own. And the NIH supports research in this area, looking at alternative and complementary medicine. And I can only look to see that there will be more research that's coming in from not just this country, but from all over the world in this area.
Now, the other area of research is really peer communication. Communication and best practices among clinicians. Our company has trained over 18,000 clinicians worldwide. How important is communication within the community of GT important to updating and evolving our technique and our education?
Well, the roots of this practice was based upon people treating patients and finding out, did it help or didn't it help? What were the outcomes? And by sharing that collective experience, we've been able to develop treatment protocols that we have evolved over time that have been applied to a variety of patient diagnoses. It started primarily with looking at the effects on tendinosis or a ligament injury. So that's a type of connective tissue injury, and has expanded to a plethora of diagnoses that would include lymphedema, women's health issues, scar tissue, muscle injuries. And as we've gained this information through communication with clinicians in the network that we've established, we're able to continue to evolve our approach and our protocols.
Back in the early days, we were actually requiring our providers to provide us with their outcomes. Actually, our business model was quite different back then, but we were forced to learn from each other. And back then we only had a handful of clinicians using these instruments and only a handful of clinicians to learn from. Now that we have over 18,000 clinicians, we have this tremendous network. Whereas Terry mentioned, we're expanding into other areas, other indications, pediatric torticollis. It's been fascinating to be involved with this and just to see how this technique has grown into different areas, into different specialties. As Terry mentioned, initially we were primarily treating the primary soft tissue lesions, things like tendinopathies and ligament injuries, where now we're treating things like, say, like lymphedema, women's health issues, pelvic floor pain, infant torticollis, scar tissue. The indications have just really broadened, and it's been fascinating, the different areas we've been able to expand into.
And we mentioned 18,000 clinicians worldwide, but I'll focus on, the company currently has 50 to 60 instructors of Graston Technique. And these instructors, very similar to Mike, are top of their game. These are expert clinicians and obviously have areas of expertise that they're willing to share. How important is that as an instructor, in addition to being a clinician, to hear those best practices?
Well, that's extremely important. That's really how we stay on top of our game and to ensure that we are providing the best interventions to our patients. Something that we haven't even brought up, we are in the curriculum of, I think, 57 different universities, whether it be an athletic training program, a physical therapy program, chiropractic programs. We're looking into an occupational therapy program currently. So we have faculty instructors on our team who, as Terry mentioned, can provide independent research. And so that's become extremely critical to our success and to our knowledge base.
Now, obviously, no education is ever static. Terry, you were involved with the beginnings of the M1 class and involved with each of the 3 revisions of our M1 manual. And Mike, you've been teaching this class for a long time. Take me back a little bit to the origins. You mentioned since inception. Mm-hmm. So let's go back to the beginnings of the M1 basic training. It was one of the first courses ever offered for instrument-assisted soft tissue mobilization. What were the goals and objectives at that time?
The goals were primarily for clinicians to be able to demonstrate the technique at a basic level of competency and to provide the instrument-assisted soft tissue mobilization in a safe and effective manner. The focus of the first module is to learn how to handle the instruments and to apply those instruments to the different regions of the body in an effective way. And without that training, then there wouldn't be that level of assurance that the clinician has a basic level of competency to deliver the technique in a safe and effective manner.
And you were there in the beginning. Mike, you're currently there now. You not only were beginning as an instructor in 1998, but you're a current instructor of the Graston Technique. In your mind, how has the course and the education changed over those years?
When I look at Module 1 specifically, we are not causing inflammation with a lot of different conditions. We are not creating microtrauma with a lot of different conditions. We've expanded our indications to a much broader spectrum of patients. But then I think about our Module 2 and how our Module 2 is just dramatically different. And I know we're going to talk about that in a separate podcast, but just by incorporating things like motion, working fascial interfaces, we are doing things in Module 2 that nobody else is doing, I would venture to say, with their hands, much less with an instrument. And that's just extremely exciting to see the outcomes that we're getting.
Well, in the future of healthcare is interprofessional collaboration, and that's another opportunity that this technique has offered to us, is that we've been collaborating with professionals from multiple disciplines since 1998. We started with athletic trainers, physical therapists, occupational therapists were a part of our very first training, and we've expanded to chiropractic medicine and massage therapists up in Canada, and nurses and doctors.
And Terry brings up a good point. Traditionally, a chiropractor is going to come at an orthopedic injury from a little different angle than a physical therapist. An athletic trainer is going to come at that same injury with a little different focus. An occupational therapist will come at that injury with a little different focus. So consider putting all those disciplines in the same room.
They can learn from each other.
They can absolutely learn from each other. The things that I've learned from my chiropractic colleagues are tremendous. I mean, something I would never learn in a physical therapy program or in a physical therapy-based continuing education class. And I just really value that education and that experience that I've been able to gain. And it's really, for me personally, it's because of Graston Technique. I would never have that involvement with the other disciplines would it not be for this technique.
So the depth and the breadth of information we've been able to pull together within our courses is founded in these multiple disciplines.
Given the changes in the healthcare environment today, as healthcare reform challenges the status quo, how important then is continuing education? How important it is to the clinician as well as the patient?
Well, I think we're going to be more and more restricted and limited in terms of reimbursement, and so we're going to have to be much more efficient with our interventions and with our outcomes. And there again is another beauty with Graston Technique. We can be so much more efficient with our soft tissue treatment because of things like the size of our instrument, the treatment edges and whatnot. That's something that I've noticed from personal experience. The instruments allow me to feel things that I just miss with my hands, and so I feel like my treatment interventions are so much more specific by addressing some of these subtleties that you just don't feel with your hands.
So what this means is better outcomes quicker, which is a savings to the healthcare system. And it's so important that all of our professions require continuing education in order to maintain our licenses. That's a requirement, but as conscientious healthcare providers, we want to be able to offer best practice, state-of-the-art care. And by having continuing education, that's one of the ways to assure that you're able to give that to your patients. We are considered to be lifelong learners as a part of our core values in our profession, and having a continuum of continuing education supports that.
Well, I'll make sure that the company stays committed to the educational process and to the research process. I guess equally, I want to make sure that we stay committed to clearing up any misconceptions. Obviously, the things that were taught or research that was done 10, 15, 20 years ago may not be applicable today. For example, bruising. Obviously, an issue with people who were trained years and years ago, but not necessarily part of today's curriculum.
We definitely addressed that issue in our trainings, and back in 1999, there was a research study that came out on instrument-assisted soft tissue mobilization that showed the more pressure you use, the more fibroblasts you produce. And we know that fibroblasts produce collagen, and so we think that's a good thing. But people started thinking more was better and started getting very aggressive, very heavy-handed with the instruments, thinking that they were helping their patients more by being more aggressive with them and damaging healthy tissue and causing the successive bruising. And we definitely learned from those mistakes, and the research has definitely shown that you don't have to be that heavy-handed, you don't have to be that aggressive. That is probably one of the biggest surprises from our participants when they attend our trainings, is how less aggressive this technique is than maybe what they would have first thought. And you come at your patient with a tray of metal instruments, it's intimidating. But it's refreshing when the patient can experience the technique properly and they notice that it's not near the uncomfortable intervention where they may have thought it was, or maybe the rumors or maybe the YouTube videos, the old YouTube videos that are out there and may have indicated. But if you are doing things like a cross friction with your fingertip properly, that is not a pleasant experience. If you are treated with Graston Technique properly, in a similar fashion, it's a much more tolerable treatment, which I know is counterintuitive. You think, how would a metal instrument be more comfortable than a fleshy fingertip?
Well, this is a much broader surface.
But it is, and it's, you'd have to take out the slack of the soft tissue and whatnot, but the treatment edge is so much more precise than the pad of your finger. So it's so much more of a tolerable treatment as well as a more effective intervention.
And I think it should be noted that those original studies were done on rats, Well, this is humans that we're treating, and so when you take it from that animal model to the human model, there is that realm where you have to work within patient tolerance, which everybody does, but you also have to work with that specificity to the level of the lesion so that you're isolating any pressure to the area that's involved and not inadvertently causing microtrauma to the surrounding area. Also, again, the original treatment diagnoses were more of your degenerative processes like a tendinosis. And so we started off by recreating the microtrauma to help promote that tissue healing and repair. But there's so many conditions that don't require that. They come in at different stages of recovery or different types of pathology that you're focusing on reducing edema. You're not going to apply the pressure that would be high pressure at all. It would be light pressure in order to help move that fluid out of that area. So it's much more, the parameters are tailored that are specific to a given condition.
And I found too in our trainings we do spend much more time talking about those parameters and the dosage of the intervention, and we've learned proper dosage through experience, through research.
And that needs to be validated by controlled clinical trials to really find out what those optimal dosages are for different patient types, ages, conditions, stages of recovery. There's multiple factors.
And that really goes into the importance of the education process. You know, there are a lot of tools out there that you can buy and use to do soft tissue work, but where do you get the education to use them? You know, where do you learn about the dosage? Where do you have the research backing that up? I'm proud to be affiliated with an organization that is committed to the research and the continued research to show that we are using these in an appropriate intervention, based on found research.
The one thing we've always said is that it's not a cookbook approach. And so if all you're limited to is a sheet of paper that says this is how you do it, it's not going to give you that clinical expertise as you would in a continuing education.
Well, it's certainly been a pleasure to review the history. We go back 20 years now. This company has been around. I can speak to our commitment going forward, and we'll make sure we maintain that commitment to the education and to the research element of what we do. And certainly want to thank the both of you for your efforts, not only in the past, but also going forward, because as you know, the technique will continue to evolve. Thank you for joining us today for the Graston Technique Forum. Our next video will feature our M2 advanced training and the benefits of advancing your GT skills to the next level. Again, thanks for joining us.